Good morning. My name is Erica Ludi. Along with my co-moderators, Dr. Federico Serrat and Abby Hatcher, it is my pleasure to welcome you to the Emory Global Perioperative Alliance Interprofessional Collaboration Symposium poster session. We are very excited to have you here and to showcase the work of all of our presenters. We have 13 students, trainees, and surgeons presenting work to you on a variety of topics, including research projects, education projects, clinical cases, and other out-of-the-box categories. Each presenter will have 5 minutes to present their work, and we will have a 3-minute live question and answer session after their presentation. We encourage you to speak up during the question and answer session and ask questions of our presenters. However, if you prefer, you can put your questions into the chat during the presentation, and we will ask the questions for you on your behalf. We are very excited you're tuning in, and we hope you enjoy the work that our students, trainees, and surgeons have worked so hard to put together for you. We look forward to seeing you at the end of the session for a live networking session that we are hosting as well. Have a great morning.
Good morning. I'm Dheera Nanthakrishnan. I'm one of the orthopedic spine surgeons here at Emory University in Atlanta. I'm presenting our project on capacity building algorithm for spine surgery in developing countries. I would like to thank my co-authors from around the world. So the purpose of the study was to outline an LMIC specific algorithm for the safe surgical treatment of spinal diseases based on diagnosis, procedure, and institutional capacity. The algorithm focuses on human energy and resources, including organizational management and logistics. And just a little word about human energy. So this is a concept that's really taken from the management and business literature. And the idea is that it basically refers to the work and activity and human power that is brought to an organization or a system and drives it forward. So this concept is, we think, underutilized in low and middle income countries. And so this idea is that the low and middle income countries can use the untapped power of their human energy to make these systems work. So we looked at 4 global sites currently providing different levels of spine care. The Lancet Commission key factors were key in this algorithm: infrastructure, workforce, service delivery, financing, and information management. We separated the spine diseases into categories, and then we separated the case mix into categories as well. So basic, intermediate, advanced, and very advanced. And this refers to not only the skill set and infrastructure required to do the case, but also the care required of the patient perioperatively at all levels. And then we basically broke down each of these levels into what was needed: infrastructure, service delivery, workforce, finance, and information management. And you can see we've outlined essentially at each level what is needed to provide care at each of these levels. And you can see it's a pretty detailed analysis about what we think is required. Obviously, 100% of these would not be required, but possibly 80% of the category of the items in each category should be available to provide that level of care. So looking at the individual sites, the Southern Philippines Medical Center, this is a solidly intermediate site and has local surgeons providing care. They've been providing care for over a decade. They have a PAC system, electronic medical record. They do the intermediate surgeries routinely. Occasionally, when visiting teams come, they'll move into the advanced category with scoliosis surgery. Takuta Hospital in Sofia, Bulgaria. This is a Scoliosis Research Society site, and along with visiting surgeons, donations, and training, this has led to them becoming a regional referral center, and they independently do adolescent idiopathic scoliosis cases. And next is Green Pastures Hospital in Pokhara, Nepal. This is a solidly basic category, but they occasionally will move into the intermediate category, providing posterior fusions. And then lastly is Muhimbili Orthopedic Institute in Dar es Salaam, Tanzania. This is an intermediate hospital. They have a full staff of neurosurgeons, residents, and registrars with elective and emergency cases provided, and they'll occasionally move into the advanced category. They actually have fellows pretty much around the whole year from Cornell in New York, neurosurgery fellows that help with keeping their systems running. So a common belief is that the material resources are what are holding these countries back from providing spine care, in particular instruments and implants. But this is not really always the case. And even in a case such as this one that I've outlined here with an incomplete paraplegic patient who has a posterior spinal fusion surgery performed, if the antibiotics are not given in a timely fashion, the beds aren't working, the patient is not mobilized, et cetera, it can lead to extended bill and hospital stay. The patient actually is no better off, possibly even worse off after the surgery. And one could inquire as to whether or not this patient was better off without surgery. So in conclusion, we can say that safe spine surgery is possible in these countries. This algorithm allows us to assess capacity and then provides a path forward to capacity amelioration. It could provide a system level of classification similar to the trauma system, level 1, 2, and 3, and really utilizes the untapped power of human energy in these countries. Thanks very much.
I have a question from a quality rather than a quantity perspective. Have you spoken with any patients directly who would have rather not had a surgery after they received any procedures? In hindsight?
Yeah, I have. I've actually that kind of simplified hypothetical situation actually tends to happen a lot, especially if there is not enough preoperative education as to what the goals are with the surgery. An incomplete paraplegic is probably a little bit different than a complete paraplegic. So a lot of times in these settings, people will think that the goal of surgery is to get someone to walk, especially if there's actually a foreign team there. So that becomes very tricky, right? Because even here, that surgery is not going to get people to walk. The goal of the surgery is to mobilize the patient really and get them moving. So I think that there are things that are lost in translation, and we get really, really focused on the technology oftentimes and kind of lose sight of the other stuff. In that hypothetical situation, there were a lot of people that could have really helped out. I remember when I was a resident, and a fellow, I was going and getting patients out of bed myself. I wasn't waiting for physical therapy. We had a lot of patients' family members that were taught how to get people up. I trained at Cook County. That was a standard thing. That's a resource limited setting as well. So I think trying to get people out of their regular roles is really important. We've actually run into that problem even here. We're trying to streamline our OR here. So getting people to do things that maybe they don't perceive as initially their job. I think it's really important to try to utilize the human energy that's there and try to repurpose it. And I think people are very fixed on their roles, which should be a little bit more fluid than they are.
I have a quick question. That was a great presentation. What do you think is happening now with COVID? Now, we have very few, we don't have access, at least to family, to come into the hospital, at least. Do you think that's going to affect? And then also, has this algorithm been used up to now somewhere, or is a future plan to use it?
No, it's a future plan to use it. So those sites, I actually, with a couple of colleagues, have started an NGO where we've actually mobilized surplus implants to developing countries, in particular hospitals. So those are three of our sites. And so we're actually implementing this algorithm over there, and hopefully trying to work with the AO and like other global organizations to try to really try to stratify into who's doing what, because there are a lot of things that are going on, even safely. But to your point about the family, I mean, we're running into that problem even here. We've had some complications here at the Orthopedic and Spine Hospital that, to be honest, might have been avoided if the patient's family member had been in the room. Some catastrophic complications. So it is kind of difficult. Actually, a few of those sites have actually gotten their own implant access through their government, so that's actually been really helpful. And it's we're trying to work with telemedicine, but I think COVID's been difficult. But I'm hopeful.
Great.
We have one question from the audience from Dr. Roser, and this will be our final question. He said, great presentation. Who are the people who are critical to develop the algorithm?
So it was actually me and a couple of the residents. I did a sabbatical in Tanzania in 2019, and it really became obvious that implants really weren't our only deal breaker, or were not essentially the deal breaker or the barrier to care. And so we crafted this along with one of the fellows who was at MOI, that's Scott Zuckerman, who's now finishing his fellowship at Columbia. So it's been a global thing, and those other 3 sites were actually been going for a long time. So using it and to try to validate it in those other sites, and then hopefully being able to spread it across a region such as East Africa, that would be our first stop. Thanks for the question.
Amazing. Thank you so much. Our next speaker is going to be Christopher Awad. He is a medical student at the Emory University School of Medicine, and he will be speaking on pickle juice and Plerex catheters, things to avoid in case of hepatic hydrothorax.
Hey everyone, this is Chris Awad, presenting my case entitled Hepatic Hydrothorax. Please avoid pickle juice and Plerex catheters. I don't see my slides up right now, but I can talk about my case. So my case is about a 55-year-old man with past medical history significant for non-ischemic dilated cardiomyopathy with a last ejection fraction taken at around 45 to 50%, alcoholic cirrhosis, and hypertension, who ended up presenting to Emory from home with progressive shortness of breath and diffuse abdominal pain in the context of 3 recent thoracenteses in the past 30 days. Now, his weight had fluctuated pretty dramatically over the past 2 months. At a baseline of 315, he went up to 340 and all the way back down to 315 within those 2 months, despite reporting diuretic medication adherence. Now, when he reported, he denied fevers, chills, myalgias, or confusion during this course, but endorsed shortness of breath, pleuritic chest pain, and abdominal pain, in addition to a significant history of pickled food consumption. That included things like pickled cucumbers, pickled tomatoes, and pickled okra, and admitted to pickled juice consumption about 3 to 4 times a week. Now, his physical exam revealed decreased breath sounds on the right, with dullness to percussion in the right lower lobe, abdominal distension, shifting dullness, and bilateral pitting edema in the lower extremities without asterixis. Laboratory studies were unremarkable, and imaging, chest X-ray, and a CT CAP demonstrated a large, simple appearing right pleural effusion with associated passive atelectasis and lung collapse, most notably in the right lower lobe. His presentation of shortness of breath and abdominal pain in the context of redeveloping pleural effusions on the right side and significant pitting edema on exam was concerning for hepatic hydrothorax, complicated by worsening cirrhosis. He was treated with 5 days of IV diuretics and a therapeutic thoracentesis that drained over 2,800 milliliters of fluid. That was significant for LDH of 79 and a total protein less than 3 grams per deciliter, which, when compared to his serum levels, fulfilled Wells' criteria for transudative process. He ended up being discharged with only educative materials around dietary habits to better help control his hypertension and his diabetes. Now I would show, if the slides were up, a picture of his imaging because I wanted to talk about how hepatic hydrothorax refers to the presence of a pleural effusion, which is something generally greater than 500 mils of fluid, in a patient with a history of cirrhosis, and occurs actually in 5 to 10% of these patients. Hepatic hydrothorax probably does occur from the passage of ascites from the peritoneal cavity into the pleural cavity through small diaphragmatic defects, which occur more commonly on the right side. Now, when patients breathe, the negative intrathoracic pressure generated during inspiration promotes the passage of this fluid from the abdominal cavity into the pleural space. This theory happens to be supported by some technetium studies that demonstrate unidirectional passage of these markers from the abdominal cavity to the pleural cavity. Now, the case presentation, I really wanted to emphasize that common clinical manifestations in patients with hepatic hydrothorax include presenting signs like dyspnea, a non-productive cough, pleuritic chest pain, and fatigue due to hypoxemia. And holistic management of patients like this for judicious surgical intervention includes a careful physical exam, percussion or scratching for the size of the liver to determine hepatosplenomegaly, in addition to percussive investigation of the thorax and abdomen to elucidate the extent of pleural effusion and or ascites, can be combined with techniques that allow for a high level of specificity on physical exam, including an increased JVP in the setting of a positive fluid wave, an elevated A wave, jugular venous waveform, unilateral changes in auscultation and percussion of the lungs, with symptoms of dyspnea, fatigue, and potential orthopnea. Taken together in the context of a holistic evaluation, this can lead to a refined diagnosis of hepatic hydrothorax without imaging and proper intervention for long-term management, especially in areas where populations have systemic challenges to recovery in the postoperative period. I would have liked to show you a picture here of of the imaging before and after his thoracentesis, because we wanted to document here an uncomplicated course of recurrent hepatic hydrothorax in the setting of extremely high salt-containing diet that, because of a good history, was managed with dietary and pharmacological treatment, diuretics, saving our patient from the risks associated with surgical placement of a chronic indwelling catheter. Thank you all so much. So I think basically the two main points that I wanted to communicate is, number one, we can actually develop really high specificity with our physical exam by combining high physical exam maneuvers that allow us to, dial in on the diagnosis of hepatic hydrothorax. Generally, the diagnosis is something that would be corroborated with imaging and is usually a diagnosis of exclusion. And so in resource poor settings, when you might not have the opportunity to get that imaging, we can combine our judicious history with specific exam maneuvers to help us understand what interventions might be needed. In addition, the other point that I wanted to make sure to bring up today is that taking a good history is super important, because when we decide to intervene in someone's life surgically, we want to make sure to understand that that is the best for their course. And in this case, understanding that this person's diet contained really, really high amounts of salt actually saved him from placement of a chronic indwelling catheter, because that dietary correction or the conservative measures that we ended up implementing saved him from this procedure.
Chris, I was wondering, how did you educate this patient on the back end, and not only in the moment, but like continually educating and saying, you can't keep ingesting this much sodium?
Yeah, thanks, Abby. So I think this was done with a lot of sensitivity, because of the fact that, when we decided to really dig through his history, he endorsed the fact that, he had a garden, he wanted to grow his own fruits and vegetables, and those were things that we wanted to make sure to encourage. It was the fact that he, as part of tradition and part of what he loved to do with his family, he wanted to pickle a lot of these fruits and vegetables or preserve them in some ways. And so what we did was we really broke down for him some of the things that he was engaging in his daily life, and tried our best to pinpoint specifically what are we going to do when you consume tomatoes? What are we going to do when you consume okra? And that's part of the reason I listed these things, because it's about, encouraging the right things, encouraging what the patient finds both acceptable and part of their health journey, and then trying to, assuage them into making sure that they're still sticking to the goals that will help them live long and healthy lives. So it was about being really specific, about understanding what his goals were, and then about introducing our goals for his health and finding good compromise.
Awesome. Thank you so much. So I think that's all the time we have for questions, but thank you again, Chris. So the next talk we are going to have is from Reem Dawood. He's another medical student at Emory, and he will be speaking on examining global health and medical education structures for a sustainable future.
Hello, and welcome to our talk looking at global health and medical education structures for a sustainable future. My name is Reem Dawood, and along with Miller Douglas and Dr. Stephen Roser, we are based out of Emory University School of Medicine. To begin, a well-reported phenomenon is that of medical students and trainees evaluating training programs based on their global health opportunities. In light of our shared vision this weekend, this has also been seen in surgical, obstetric, and anesthesia specialties. So with U.S. medical schools continuing to integrate global health into their undergraduate and graduate medical curricula, close examination of the current landscape of global health programming is crucial. And what we saw was a notable lack of consensus on how to best design a global health curriculum or training opportunities. So our friends at the Consortium of Universities for Global Health have some excellent resources and toolkits for how to get started. But the AAMC and the ACGME, which are the governing bodies for education at the undergraduate and graduate medical training level, don't offer any global health specific competencies in order to design curriculum. Rather, curriculum are designed in order to satisfy existing competencies within these governing bodies. So in light of this lack of consensus, we wanted to take a look at programs and see what common themes emerged. So with that background in mind, our group's question was, what are the administrative, logistical, and educational structures of global health programs at U.S. medical schools? To do that, we conducted a survey of institutional websites and online annual reports. Inclusion criteria for universities were those that received the top 30 in NIH funding, 14 of which are included in this analysis. We wanted to keep in mind geographic diversity across the United States and institutional size diversity. To analyze our data, we pulled qualitative themes and constructed a framework that we will share presently. So the themes that emerged broadly fit into the following three categories. First, it was administrative, logistical, and financing structures. Then it was education and training opportunities. And finally, it was the theme of bidirectionality. So to start, established global health programs have large teams of dedicated administrative staff. This includes program management, education, research, and especially grant writing. Next were these external leadership councils composed of partners from philanthropy, industry, and other institutions, including those in LMICs, that worked with intra-institutional leaders. So we posit that this council facilitates funding, access to resources, and planning with partner institutions. And finally, while extramural funding drove projects, it was actually philanthropic or institutional funds that supported education efforts. So within the realm of education efforts, established global health programs have education hubs, vertically structured so that graduate and undergraduate medical trainees can receive their training kind of in a similar area. This also allows for administrative staff to handle responsibilities along one continuum, increasing efficiency. And like we had reported earlier, since there's a breadth of folks who are looking for these training opportunities, we're happy to see that there are many specialties involved in education and further training. Finally, touching on bidirectionality. These programs depended on established long-standing relationships with institutions and hospitals and LMICs that supported programming across many departments. And finally, what we were glad to see was that in some cases, physicians and faculty from LMICs were able to be financially and otherwise supported in also to continue training in the United States. Now that we have the beginnings of our data set, we're asking the following questions. So our analysis is far from over, and we're planning to include many more institutions in our analysis. Second, again, in light of our shared vision this weekend, what is the role of surgical, obstetric, and anesthesia departments in these efforts? As you know, Centers for Global Surgery have rapidly expanded in the United States in the wake of the Lancet Commission on Global Surgery and acceptance of surgery as a global health issue. So we want to more closely see how these centers are kind of operating in tandem or within existing global health frameworks. Next is addressing a limitation in our study method, which is our data was collected by web-based searches. And again, part of why we're glad to be here this weekend was to hear from those in the audience about experiences with their own global health departments. And finally, we think it's important to understand why an institution is embarking on global health programming in the first place. So looking to our own student body and trainees, assessing motivators for wanting to be involved in global health, evaluating whether participating in global health activities can actually function as burnout protection, and across all institutions in the US, what is being done with regards to faculty development and retention as the career path of a global health physician, and especially the global surgeon, is being better defined. With that, we'll be happy to take your comments and your questions. Thank you for your time.
Wonderful. Thank you so much for your talk.
Thank you.
As previously, I'll read any questions in the chat.
Sure.
If Dr. Ludi or Dr. Serrat have any questions.
Mm-hmm.
Well, Rim, it was a great presentation. Let me ask you something. In your experience as a medical student, when did you get involved and how did you get involved in global health? Because this is also important, right? Is that to try to get students involved from the beginning, because getting involved now will bring you, once you decide whatever you want to do, specialty wise, it will keep you engaged. But what do you think the different universities and medical schools should do to involve more and more students so that we can continue to develop this type of program?
I think we've heard from a lot of students today about examples about how to get involved in global health as they progress through their career. One way I've thought about using this information as a medical student is saying, in evaluating schools, it seems like there's a lot of infrastructure that needs to be in place before you can ethically and sustainably be involved in global health. So students and trainees looking forward to planning their careers and kind of look through administration, funding, education programs, and bidirectionality kind of cues to say, this is a program that's really thinking about global health kind of as a wraparound project. Another way I thought about this is, as the student, we are all very clinically focused. We want to kind of help out with the patient as best we can, but it's important to also take a step back and say, maybe, I can get an MBA or an MPH and learn about administrative structures and funding structures to get involved in global health. Or if I'm really interested in education, developing educational tools, in order to better advance global health practices. So thinking about things not just clinically, but the whole picture.
Great. We have a question from Dr. Reitz. She asks, how can US-based academic institutions make sure they are focusing their efforts on the needs of global sites as well as trainees?
I think that's a really important question. In looking through this data, the most sustainable programs have been developed when a US university or institution partners with a university or institution in LMIC. So that way, folks all the way from the attending level down to the medical student level can have a partner along in the process and feel like both are benefiting from the relationship. I think in terms of funding, looking at the current funding landscape for global health, thinking about where are those funding streams growing, where are they kind of decreasing to to be able to look and how to fund your projects or your education efforts as well.
Great. We have another question, but from Dr. Roser, but we're going to save that for the networking session since we need to move on to the next presentation. So I'll save that for the networking. Okay. Thank you so much.
Thank you.
So the next talk is going to be from Rohan Damsana, and they will be talking about early tracheostomy reduces ventilator-dependent days in COVID-19 patients.
Good morning. I'm Rohan Damsania, a first-year medical student at Philadelphia College of Osteopathic Medicine. Today I'll be sharing our preliminary findings on our analysis of early tracheostomy versus late tracheostomy in critical COVID-19 patients. Pre-pandemic data suggests better survival outcomes in early tracheostomy groups based on a multi-center study done in the US. And since the focus of this conference is to improve global surgical care, I wanted to bring up a point that this trend also holds true internationally, as shown by a study done by a group in South Korea, where the group that received early tracheostomy had significantly better survival outcomes. However, the data gets very interesting when we look at tracheostomy timing in ARDS patients. If you look at the figure on the slide, the patients come from 50 different countries, and thus it's a very diverse patient population, and the timing for tracheostomy is very varied. Thus, with the onset of the pandemic in late 2019, it was imperative to have clear guidelines for surgeons to insert or do effective tracheostomy. Some of the key factors on the guidelines are listed in the figure attached on the slide. It's important to note that one of the key factors that favors delayed tracheostomy is physician or healthcare provider safety. And this is very crucial. Based on the data of SARS 2003 outbreak, healthcare providers who did tracheostomy had significantly higher chances of infecting the disease. On the other hand, patients with increased duration of translaryngeal intubation, sedation, and mechanical ventilation have increased chances of complication. Thus, it's an interesting conundrum where we have to balance patient complications and provider safety. And our research project addresses or studies this conundrum. The hypothesis of our project is that the early tracheostomy group would have significantly lower 30 and 90-day mortality. And it's a retrospective study where we have looked at 129 COVID-19 patients who underwent tracheostomy at Emory Healthcare System hospitals between March 2020 and January 2021. And we have defined early tracheostomy as tracheostomy done less than equal to 14 days from the time of intubation. And we used REDCap and Emory Healthcare Clinical Data Warehouse for our data collection, and RStudio was used for statistical analysis. Of all the COVID-19 patients who underwent tracheostomy at Emory, 78% of the patients underwent late tracheostomy. Now we were curious to see as to were there any clinical outcome differences between these two groups. We were surprised to see that the early tracheostomy group had significantly lower days of ventilator-dependent days, and they also had significantly lower days of ICU days when compared to the late tracheostomy group. Now, we wanted to compare or look at the health profiles of these patients at the time of hospital admission, just before and after tracheostomy, and 30 days post-tracheostomy. Early tracheostomy group had fewer comorbidities upon admission, and we focused on hypertension, obesity, and diabetes, as these are the key comorbidities with COVID-19, and had fewer comorbidities when compared to the late tracheostomy group. However, the disease burden was very similar just before and after the tracheostomy group, as shown here by our disease severity markers, including Apache 2 score and pre and post partial O2 FiO2 ratios. However, the data 30-day post-tracheostomy complication data was pretty shocking in that the early tracheostomy group seemed to have higher disease burden. However, it's important to understand that this is very preliminary data, and also there's no real direct association between tracheostomy, between the performing tracheostomy procedure and arising of these outcomes. Thus, there are key important points. Early tracheostomy significantly reduced ventilator-dependent days. early tracheostomy significantly reduced ICU days, and early and late tracheostomy groups had comparable disease burden and 30-day mortality rates. Our future directions include continuation of data collection with our domestic and international partners in Bolivia and Spain in order to capture an extensive and a diverse patient population. In addition, we will be continuing to analyze our healthcare provider data in order to have better understanding of both arms of the conundrum and thus be in a better position to effectively understand and address the conundrum of effective timing for tracheostomy. This is my research group. They have been instrumental in their support and guidance throughout this project, and I'm very excited to be working with them. And these are just some supplemental data sets, shows our in-depth statistical analysis. Thank you.
Thanks, Rohan. Great talk. We have a question from an audience member, Dr. Sharma. He said, enjoyed your presentation on early trachs. What was COVID treatment with remdesivir and antibody in IN2 groups? Antibody IN2 groups.
Sorry, the second part of the question, like I could not hear that.
I can repeat it.
Can you please repeat?
What was the COVID treatment with remdesivir and antibody IN2 groups?
Sorry, so was the question, what was the COVID treatment with remdesivir and the antibody group?
Yes.
So based on we reviewed, for inputting patient data, we reviewed their patient charts, and remdesivir seemed to be the most common treatment in most of our patients, most of our trach patients, either early or late trach patients. However, we did not compare differences in the treatment between the two groups yet, and that'll be an interesting topic to do further analysis on.
Wonderful. Constance is also kind of chiming in the chat as well. Another
Rohan,
question.
that was a great. Oh, go ahead.
Another question from the chat. Why else do you think that the prelim data showed that early trach groups demonstrated a higher burden?
So post-trach, the early trach did show higher burden. There could be several factors for this. One factor being this is a preliminary data. So once we have higher numbers, more number of patients, more diverse patient population, we might see different results. And second reason being all the comorbidities or all the side effects that come up after a trach there's pretty much no direct correlation between the procedure of tracheostomy and the side effects that come up post 30 days trach. And so that just could be the nature of the disease progression in those cases, and thus could be independent from the procedure of tracheostomy.
And then our last question, Dr. Roser asks, is there any data on the transmission of COVID to providers from COVID positive patients receiving trachs that you've come across?
Yes, that's a very good question. So that is our second part of the study where we want to understand whether COVID healthcare, the tracheostomy healthcare providers have higher chances of infectivity or not. And we're in the process of collecting the data, and our very preliminary data suggests that the infectivity does not increase in healthcare providers who do perform tracheostomy. And we will be collecting, again, more provider data from different institutions locally and globally to have more broader perspective.
Wonderful. I look forward to reading about that.
Rohan, this is a great presentation. And even if your final data shows no changes in prognosis of the patient, especially in countries, undeveloped countries, just the fact that you can give a chance to someone else to be on a ventilator that may need a ventilator is what you want the most, right? We're lucky in the United States. We got to a point where it was difficult, but most of the countries in South America, Asia, I know from South America, you want to give them a chance to someone else, right? So I think even that data would give, would be still important to know. So great presentation, Raham.
Thank you very much.
Wonderful, thank you. Okay, so our next presentation will be from Christian Faber Anderson, who is a Emory medical student, and his talk is titled An Evaluation of Surgical Outcomes of a Short-Term Cataract Mission in Peru Over 10 Years.
Good afternoon, my name is Christian Faber Anderson, and I'm a third-year Emory medical student. The title of my presentation is An Evaluation of Surgical Outcomes of a Short-Term Cataract Mission in Peru Over 10 Years. A cataract is an opacity of the lens of the eye that causes distorted vision and in advanced cases can cause blindness. Importantly, cataracts represent the leading cause of blindness worldwide. In Latin America, an estimated 10.8 million people are visually impaired, with cataracts accounting for 47 to 87% of vision loss across the continent. Cataracts place an immense burden on individuals and their communities where vision loss hinders educational and economic opportunity, reduces quality of life, shortens lifespan, and disrupts the lives of caregivers. The high prevalence of cataracts in developing countries, coupled with its immense burden of disease, has led to the growing deployment of short-term voluntary surgery trips whose impact remains largely unmeasured. Thus, as these medical service trips have grown, so has the need to critically evaluate their role in delivering high-quality eye care. With this in mind, our goal for this project was to perform a longitudinal retrospective assessment of the postoperative outcomes of an annual short-term cataract program in northern Peru, with the aim of assessing surgical outcomes compared to 1, WHO established standards, and 2, local surgeon outcomes, as well as in order to improve the mission's outcomes itself. In order to achieve this, we performed a retrospective chart review of 312 cataract surgeries undertaken by a team of experienced American eye surgeons over a 10-year time period. Prior to presenting these findings, I'd like to clarify what I mean by WHO established standards and local surgeon outcomes. The WHO has defined standards for good cataract outcomes as at least 80% of operated eyes achieving 6/18 or better uncorrected visual acuity postoperatively, with borderline and poor visual outcomes limited to less than 15 and 5% of cases, respectively. Local Peruvian outcomes, as described by a regional institute in northern Peru, show a baseline distribution of good, borderline, and poor cases at 24, 44, and 19%, respectively. Now, there are really 3 key findings I'd like you to take away from our study. The first finding from our analysis of the 312 patients that underwent cataract surgery through the charitable mission was, unsurprisingly, a statistically significant improvement in visual acuity 1 week after surgery. Here we use the logarithm of the minimal angle of resolution, better known as the LogMAR scale, which is essentially a scale commonly used in ophthalmology to quantify visual acuity, where a score of 0 corresponds to 20/20 vision. Thus, the lower one's LogMAR score, the better one's visual acuity. And here you see a decrease in the mean LogMAR score from 1.5 to 1 7 days after surgery. This roughly corresponds to going from 20/600 to 20/200 vision. The second key finding describes how the distribution of good, borderline, and poor results compare to WHO guidelines. The frequency of good cataract outcomes in the study fell more than 50% short of the WHO designated benchmark at 1 week post-surgery. While the proportion of good outcomes rose from 28 to 44% at long-term post-operative outcomes, this rate still significantly failed to meet the WHO standard of greater than 80%. Alarmingly, the rate of poor surgical outcomes remained over 4 times higher than the WHO target of less than 5% at long-term follow-up. The third key finding from the study describes how the distribution of good, borderline, and poor results compare to local Peruvian outcomes. And here we see that the outcome profile is really quite comparable, though it is worth noting that these visual acuities were measured at 30 and 7 days post-op respectively. Our study also had a similar complication rate when compared to local surgeons, offering no evidence that visiting ophthalmologists provided a superior standard of care in cataract removal. So in conclusion, the short-term cataract mission in Peru yielded a statistically significant improvement in patients' visual acuity after surgery, and the distribution of good, borderline, and poor outcomes were comparable to local surgeon outcomes, but fall short of WHO recommended guidelines. and a deeper exploration of the variables driving these outcome discrepancies is certainly necessary. Because the outcome profile of the charitable mission at hand is similar to that of Peruvian surgeons, there's a strong indication that these variables are structural in nature and less related to the differences in experience between visiting and Peruvian physicians. Thus, we advocate for further research into the underlying barriers to effective eye care, particularly in relation to how things like lack of transportation, lack of family support, fear of surgery, and a poor physician-patient communication may affect cataract outcomes in Peru. And with that, I'd like to thank Dr. O'Banion for her mentorship and for allowing me to take on this project, and I welcome any questions the audience might have.
Wonderful talk, Christian.
Thank you.
We do have a question in the chat from Dr. Sharma. He asks, or he says, enjoyed this analysis, and asks, what was the experience level of the practitioners, and were trainees or learners performing any of the procedures?
That's a really great question. So 95% of the surgeries were performed by experienced American ophthalmologists. There were some fellows there, but 95% of the surgeries were performed by attending physicians.
Great presentation, Christian. I have another question for you. You know, when you look at these numbers and the outcomes, you know, one question would be, do you think the population that is being served by these, you know, visiting ophthalmologists is different from, you know, the regular, you know, probably not as rural population that's being taken care of by, you know, ophthalmologists back in Peru? That's number one. Let's start with that.
Sure. So I think this gets to kind of the heart of what the analysis is really telling us. And there's a kind of a line in an analysis from a person whose name is Dr. Lindberg, who's very intimately kind of associated with this research. And it is the extent of a health system's development determines the level at which achieving optimal outcomes is faced. And so, like you were saying, in northern Peru, in a resource-limited setting, it might be valuable to invest some of the more resources in sort of developing a more adequate medical infrastructure at that level, rather than sending cataract surgeons down there on a short-term basis in order to alleviate sort of the backlog of surgeries there, which is an important component, but perhaps is missing some of those structural factors that are really causing the poor outcome profile that we see when compared to WHO standards. And interestingly, you'll see in places like Buenos Aires, neighboring countries, they are meeting those thresholds of 80% outcomes being good. So I think that does speak to your point that there are regional differences related to the medical infrastructure there. And I think the point of this talk is really asking the question, how should we allocate our resources, and what's the most effective way to achieve an equitable distribution and an appropriate distribution of outcomes in these kinds of places?
That would be an interesting project for you. You know, look at education that, you know, can help those patients. There's more questions, I think, from the audience.
There are. I'm going to try to kind of combine them in one. So Dr. Ludi said one challenge with short-term missions is long-term follow-up. Do you know what kind of care is needed for cataract surgery patients? How is that being addressed by this group? And subsequently, Chris Awad asked, was there any structural issues the team would prioritize investigating moving forward? So, you know, is the long-term follow-up a part of the kind of infrastructural difficulties that your team faced?
Yeah, those are phenomenal questions. So I think, well, what the data showed was that at post-op day 1, 90% of patients returned after having their surgery, but that fell to 69% at 7 days after surgery. So around 30% of patients weren't coming back just 7 days after their surgery, and it was around 50% of patients returning about a year after their surgery. So there's a huge lack of follow-up, and then the question becomes, well, what's causing that? Is it lack of transportation? Many of the patients had to take many buses in order to get to the clinic. Is it poor communication? Obviously, they're speaking Spanish and indigenous languages there, and perhaps the American surgeons weren't adequately communicating the importance of returning for follow-up. Was it lack of medical resources at the facility? There could be so many things, but I think the take-home message is they're often structural in nature and much less related to the actual caliber of surgeon. And that's evidenced in the fact that American visiting surgeons who have tons of experience are having a same sort of complication profile as well as outcome profile as local Peruvian physicians are.
Wonderful. Well, thank you so much for your talk.
Thank you.
Our next presentation will be from Dr. Elizabeth Jacob with a presentation titled A Rural General Surgery Resident's Guide to Volunteering Internationally.
Hello, my name is Elizabeth Elsie Jacob. I am a third-year general surgery resident at Facet Medical Center. I'll be presenting on getting started in international volunteering from a rural general surgery resident's perspective. Despite the similarities to international and rural surgery, there are several challenges to volunteering abroad. There is often a lack of infrastructure for those who come from a rural surgery background. There's often no dedicated time off to allow for such an opportunity, and faculty and co-residents are less able to support those opportunities as the surgical burden of disease is very high in rural America. Global surgery can be defined as follows from the British Medical Journal. It's an area of study, research, practice, and advocacy that seeks to improve health outcomes and achieve health equity for all people who need surgical and anesthesia care, with a special emphasis on underserved populations and populations in crisis. It uses collaborative, cross-sectoral, and transnational approaches and is a synthesis of population-based strategies with individual and surgical and anesthesia care. Across the world, 5 billion people lack access to surgical care, 143 million additional surgical procedures are needed each year, and 33 million people face impoverishing expenditure related to surgical care. In getting involved, it's helpful to ask a few questions. What stage in your residency or career are you? What are your goals? Are you hoping to get your feet wet in international volunteering? Or are you hope to partner with an organization for the future? Where are you hoping to get involved? Is there a country to which you have a specific interest based on your personal experiences, your background, or language expertise? Or is there a specific opportunity which you might be able to lend a specific interest, such as laparoscopic surgery? When would you be going, and how much time can you commit to being abroad? If you happen to be volunteering during a pandemic, it's helpful to know what sort of restrictions might be in place in vaccinations related to that as well. Some resources that are helpful include mentors in your program or elsewhere. Often you'll find that there are attendings in your program that may know of other individuals who have internationally volunteered despite their rural background, who can provide information and resources to you. There may be fellow residents in your program who have gone ahead of you, who have invested and gone into an international rotation from which you can pick their brain for resources and advice. It's helpful to join organizations with a like-minded interest in global surgery. Again, networking with residents who may have gone ahead of you. Such organizations that I've been a part of include the RAS-ACS Global Surgery Work Group, as well as the Association of Academic Global Surgery. It's helpful to network at national meetings. At the ACS Clinical Congress, they'll often have, for instance, a global surgery panel, and it's often helpful to find individuals who attend that panel and who may be able to give you information and advice. You may find medical and non-medical friends and colleagues who also have information and resources that will be helpful to you. You can reach out to residents who you graduated with from the same medical school who may be involved or have international opportunities in their programs, and they can provide information to you. Lastly, it's helpful to think about what opportunities are out there. There are structured opportunities, including Operation Giving Back, or GHO, through CMDA. There are also more of a do-it-yourself opportunity where you're aware of a hospital or organization that could use or would be amenable to having a resident come alongside them. There are pros and cons to each. With the structured, you probably have less legwork and more so in the do-it-yourself opportunity, but the structured opportunity might have a rigid time frame, and you might have a little bit more leniency in coordinating timing if it was more of a do-it-yourself opportunity. In terms of your timeline, it's helpful to know what vaccinations, visas, and medical licensures are required for the organization and country you'll be working with. It's helpful to think about where you're going to be staying and how you're going to get there and on a day-to-day basis to the hospital you'll be working with. If you require or would like to have an ACGME approved international rotation, know that there is an application form for that, which you see in this image here. These are my references, and I thank you for your attention. I'll be happy to answer any questions you have in the Q&A panel. Thank you.
Thank you, Dr. Jacob. Sorry that the end got cut off a little bit, but thank you so much for your talk.
Thank you for having me.
One of my questions kind of relates to what we're doing right now. You mentioned that networking for students and residents alike that want to get involved and tied into global surgery and global medicine is to attend the larger conferences and network. And while we have networking built into our conference, have you found that in the last year with COVID that you've had to kind of readjust how you attend conferences and reach out to other physicians?
Definitely so. That organization, the Academic Association of Global Surgeons, I was introduced to through a networking panel, I believe at ACS Clinical Congress, where I met with other RAS, ACS members in the global surgery work group. So again, it goes back to that sense of reaching out to your network and people that you know through those avenues in order to expand the other individuals you can come across with who can guide your path and interests in global surgery. Yes, I believe so. My hospital itself that I'm coming from would be interested in, like you said, in publishing or just advancing and giving some residents and medical students even just like a framework of where to start from, because that's not something that's commonly talked about when you go through training. And I think the AAGS is also in the works of creating a kind of handbook or guide how to do these things as well.
Yes, great talk, Elizabeth. Do you think relationships between the rural programs and more academic programs will be important too, or do you think is that part of how you can also connect and get interested in global health?
No, I think it's incredibly vital to do that because we are pooling our information and advice and experiences together so that we can further our aim of just working together to improve the health globally. Like I mentioned, the surgical burden of disease internationally is astounding. And unless we come together from rural backgrounds and from more academic backgrounds, we're not going to be able to tackle this effectively.
That's true. Thank you. That was a great presentation.
Yes, thank you.
Thank you, everybody.
Our next talk will be from Sarah Kabidi, Emory medical student. and she will be speaking on modernizing medical education for the global audience.
Hello, everyone. Thank you so much for joining us. My name is Sarah Kavidi, and I'm a third-year medical student at Emory University. I'm really excited to share with you our recent project, the Loop podcast, and the role we see it playing in medical education around the world. Although this project was submitted as part of the out-of-the-box category, I've tried to structure this presentation in a familiar format, so we'll be working through each of these 4 boxes. I'm sure many of us at this symposium are intimately aware of the substantial impact COVID-19 has had on medical education and training. And essentially what it boils down to is the fact that traditional modalities for medical education were simply not developed with a global pandemic in mind. Given the importance of social distancing, there has been an increased need for virtual and remote learning, and thus a new reliance on unconventional mediums such as podcasts to use as educational tools. While education from the medical student level through fellows and across all specialties have certainly been impacted, I think it's important to highlight the unique challenges faced by surgical training programs, specifically those which rely heavily on elective operations, as is the case with plastic surgery. So that brings us to the utility of podcasts in medical education. There are some obvious benefits, such as the fact that they're free, can be accessed by anyone around the world. Podcasts are also capable of delivering socially distant and asynchronous learning, which can be really appealing to learners and trainees. More specifically, though, podcasts are incredibly efficient. They can cover very narrow, high-yield topics and can be listened to in virtually any setting. And this has particular importance to surgical trainees, as multiple studies have found that the #1 cause of burnout is long work hours. So where we can optimize efficiency, we can minimize burnout. All of this points to the growing popularity of podcasts. And in fact, a recent study showed that many trainees found podcasts to be more worthwhile than their traditional didactic lectures. Fortunately, podcasts already exist in nearly every medical specialty. However, a recent review found that plastic surgery was in the bottom third of all specialties when it came to the number of podcasts available. And thus, we saw an opportunity to create the Loop podcast. So our co-founders are Dr. Morgan Martin, who is a plastic surgery fellow here at Emory, and Greta Davis, who will be graduating soon from UC San Diego. They then recruited residents from 3 separate institutions to join as core hosts of the podcast, and also included 2 medical students, including myself, as part of the core team. As you can see, one of the things that makes the Loop podcast unique is its diverse core team and a multi-institutional collaboration. As far as the actual content of the podcast goes, we recently finished our first season, which focused on in-service review. Each episode covered a specific ACAPS topic and its high-yield concepts. Podcast episodes were structured as a simple conversation between the 2 hosts in a very naturally flowing way, as opposed to an interview. Additionally, for every episode, we also published a presentation with visual aids and key reference material on our YouTube channel. So in order to grow our listener base and reach a broader audience, we have worked incredibly hard to cultivate a strong social media presence across multiple platforms. And at this point, I'd love to encourage all of you to go ahead and check out that hard work at the Loop podcast, which is our handle. We have been using a platform called Buzzsprout to publish episodes, and this allows us to publish our podcast to all of the platforms you see listed, as well as track our progress and our analytics, which leads me nicely into our results. So in less than 3 months, we have published 28 episodes, which have been downloaded 7,299 times. Additionally, the videos on our YouTube channel have received over 2,000 views. Perhaps unsurprisingly, the most popular device used to listen to our content has been on mobile devices, and more specifically on iPhones. Again, it perhaps goes without surprise that the app used most to download our podcast has been the Apple Podcast app. And of note, we have a 5-star rating on Apple Podcasts and have received numerous glowing reviews like the one you see here, which has been incredibly heartwarming and allowed us to keep pushing on. One of the things I'm most excited about, though, has been the global reach of our podcast. To date, episodes have been downloaded in over 40 countries, 600 cities, and on every continent other than Antarctica. For those that are interested, here we have listed the top 5 countries and cities. So what are our takeaways? We have been successful in reaching a global audience, and based on their reviews and the feedback we've received, have been successful in meeting their needs. Moving forward, though, we are already in the process of creating additional seasons and are working towards expanding our usership in countries outside the United States. I'd like to thank you all for your attention and give a huge shout out to Dr. Morgan Martin and the rest of the
Thanks, Sarah. Great talk, and I can't wait to listen to your podcast. We'll see if there's any questions in the chat. In the meantime, Dr. Lydia, Dr. Serrot, have any questions?
Well, Sarah, that was a great presentation. I have a quick question. How do you guys decide what you're going to be talking about? Do you guys are developing like a quick, program of what you want to talk about? Are you, and do you see more interest, from resident students? Do you know who is following? Are they students, residents? What are you guys thinking?
Yeah, so thank you for that question. As far as what topics we're covering, our first season was directed specifically to the in-service exams, which were last week. So we really pushed hard to get all of the content out for that. There's a list online of the various topics that are covered. And so each episode, we targeted a specific topic covered on the in-service exam and basically broke down the high yield information. We looked at in-service exam questions for the past 5 years to pull out the most relevant and topics that were coming up the most frequently. As far as your second question goes, I think that is a fantastic question. I'm not sure what the best modality would be to acquire that information as far as listener demographics and whether it's predominantly residents, whether it's medical students like myself, whether it's just people in the community who are listening to that. Unfortunately, with the technology that we're using, Buzzsprout, as I mentioned, it does not give us that granular of detail as far as our listener demographics, but I think that's a great question. As I mentioned in the presentation as well, we will be having additional seasons with roundtables. We're also thinking of having patient interviews, faculty talks. And so while this past season was very focused on those who were taking the in-service exam, we are hoping to include topics and seasons that will appeal to a broader audience.
Great. You guys should also look into inviting some of those people from those other countries that you have here to talk. Then you will for sure increase those viewers from those countries because they'll start spreading their word. Come watch me, come listen to me, and
Absolutely.
that will probably increase your numbers.
Absolutely. And I didn't have time to speak too much to this in the presentation, but we're currently using Clubhouse, which is a new social media app where people from around the world can enter rooms to just have certain discussions. And so every Sunday in an hour, we're going to have another one. We are able to connect with trainees, surgeons, whomever from around the world who are interested in plastic surgery, who are interested in medical education. And we've already had we've already created a bunch of really, really fantastic connections. There's one doctor in Kenya who would like to work with us. And so I think that's a great point as far as having additional guest hosts and growing the audience that way.
Awesome. We have a few questions in the chat. I don't know if we'll have time for all of them, so we can definitely talk about these in the networking session. But Dr. Roser asks a very important question. Once things return to normal, will you have time to continue the podcast? Is there a season 2 planned?
Yes, absolutely. So season 2 is already in the works. Seasons 3 and 4 are in our minds as well. So we have a really strong team here at the Loop and across the country. We're hoping to pull in some more core team leaders who are not part of the US, but again, more of that global reach. We have every intention to continue on, and we have like a 5-year plan, 10-year plan. So this is something that will certainly outlast, fingers crossed, the pandemic.
Lovely. Wonderful. Okay, well, thank you so much for your talk.
Of course. Thank you.
Our next speaker is Anish Sangari, and they will be talking about increased infection-free surgery and hand hygiene compliance inside the operating room.
Hi there. My name is Anish Sangari, and today I'll be talking about increasing hand hygiene during a pandemic, the design, construction, and implementation of a gamified hand sanitizer feedback unit. I'm a medical student at the Medical College of Georgia. Let's get started. Non-pharmaceutical interventions like hand hygiene has remained one of the key methods to decrease infections both inside the hospital and the operating room. In fact, prior literature has repeatedly demonstrated that surgical workers' hands remains one of the main methods of transmission behind healthcare-associated infections. But despite widespread acceptance of these facts, hand hygiene in hospitals remains inadequate. Prior literature has also shown that gamification of hand hygiene has resulted in substantial long-term improvement of hand hygiene. So we took the following 5 steps. We identified a target population, identified a target behavior, created structured rule sets and a clear win-loss behavior, measured behavioral changes, and identified possible improvements. And we came up with Happy Hands. Happy Hands is a 3D printed hand sanitizer feedback unit that gamifies hand hygiene by capturing the attention of nearby individuals and motivating them to utilize proper hand hygiene. Happy Hands utilizes an ESP32 Vroom developmental board microcontroller, which you can see on the far left, and 2 HC-SR04 ultrasound sensors encased in a 3D printed enclosure. We also used RGB LED units to display a red frowny face whenever a person walks by. That frowny face then switches to a green smiley face when the person utilizes the hand sanitizer unit. We designed a 3D printed enclosure for the unit using Tinkercad, as well as a printed circuit board using EagleCAD to better facilitate mass production of these units. Now, just to reiterate and to show you an example of how Happy Hands works, when anyone is walking nearby the unit, it uses one of those ultrasound sensors to detect that and displays a red frowny face using the red RGB LEDs. Then, if a person utilizes the hand sanitizer unit, that switches to a green smiley face, which you can see on the right. Happy Hands collects this data for further analysis and de-identifies all information. It quantifies it using an ESP-NOW connection and encrypts all information using a secure method called counter mode with cipher blockchaining and a message authentication code. What we're currently doing is we're seeing the extent to which Happy Hands improves hand hygiene compliance at the Augusta Hospital Medical Center. Units have been implemented there, and we're currently seeing and measuring the extent of compliance by seeing just how much people use these units. We're also in the process of getting IRB approval to better quantify this data by analyzing chart reviews of the number of surgical site infections before and after implementation of these units. And finally, we're currently reaching out to other hospital systems to expand our data collection phase and to get more data. Our next steps include monitoring the efficacy of hand hygiene campaigns, because what these Happy Hands units do by monitoring just how often people are using these units is provide a better measure of quantification for how much people are using hand hygiene, hand sanitizers. This allows us to monitor the efficacy of future hand hygiene campaigns while allowing a baseline comparison. It also allows us to document which departments are most in need of supplementary hand hygiene campaigns, whether it's specific ORs or specific departments. And finally, it allows us to better measure compliance with existing hand hygiene regulations and guidelines. In conclusion, Happy Hands represents a successful gamification of hand hygiene and a cost-effective preventative measure against the spread of hospital-associated infections. It's a low-cost product and under only $40 and can be adapted to a wide variety of different hand sanitizer units. We believe this product has large applications as a low-cost, efficacious stand against the spread of future infections, and we're excited for the next steps. Thank you so much for your attention, and we're happy to take any questions you have.
Thank you so much for your talk, Anish. I hope to one day have Happy Hands in Emory and Grady hospitals as well. That would be lovely.
Thank you so much for allowing me the opportunity to present here. It's a great conference.
Absolutely. Dr. Sharma says, innovative approach with improving adherence. Why do you think that healthcare workers are not adhering to common sense measures like this, and how did the pandemic affect adherence in your view?
I think with healthcare workers, it just becomes a bit difficult to implement hand hygiene at every stage of patient contact when you're doing it so many times over and over again. I think it just becomes a little monotonous. In previous studies and meta-analyses have reported that healthcare workers actually end up washing their hands or performing some method of hand hygiene around less than half of the times that they're supposed to be doing it. Definitely a big problem. I think the monotony is really what gets to people. And by implementing a various, whether it's Happy Hands with the green smiley face and the red frowny face, or even different interventions, all of those have been shown to increase engagement and the time people think about hand hygiene. And that ultimately, I think, is what's causing the increase in hand hygiene you see.
I think
you may have mentioned this. Oh, go ahead.
No, you can go ahead, Dr. Lee.
But aside from the visual feedback, do the users get any sort of audio feedback? They've started putting some little hand hygiene feedback boxes on the hand sanitizers at Emory, and it has a link to your badge. And if you don't, sanitize in, then it'll say, please sanitize. And so it'll kind of, slap you on the wrist for not doing it. So is there any sort of audio feedback from your game?
That's a great idea. Actually, our units currently don't have any audio feedback, but I can definitely see how adding some method of, like a nice melodious little ring every time you use the unit would encourage people to use it. So that's a great idea. I think we'll definitely bring that up with the team and try to incorporate it in future iterations.
Cool.
When you were creating these, add-ons to the hand hygiene units, how did you mitigate cost and also decide on the smiley faces, which I applaud you as a very universally, like red and green, happy, sad is a great universal symbol. But how did you come to that conclusion to decide to use that and also keep costs low?
Sure. So our units are all manufactured using relatively low-cost items, including the ESP32 item, which I mentioned earlier. It's actually a nice solution because all of the pieces that we've built in are not only optimized for cost, they're also optimized for battery life. Because when you're adding something onto these hand sanitizer units, you also sort of have to worry about battery life. But each of those units are designed to go into a low power mode. And in addition, as for the cost aspect of it, they're all mass produced, which allows us to bring these costs of these items relatively low compared to a lot of the other interventions that you might see. As for your second question about the smiley face versus other interventions, prior literature has shown, and actually a lot of you might be aware of this, this is a pretty famous psychological research study, but prior literature has shown that even adding just two eyes or a drawing of two eyes next to any activity will generally tend to change whatever that person is doing. And in the case of hand hygiene, it has been shown to be efficacious. What we wanted to do was create that sort of human interaction with the smiley face and the frowny face, and we thought that might be a little better than having like a green check mark versus a red X, for instance, just because prior literature had shown that sort of human connection to be better at driving or motivating humans to do things.
This is, again, great presentation, Anish, and I actually agree with you. It actually happens to me after they put this in my badge. I've been, just in case someone, that thing goes off, I'm going to do it, right?
Yeah.
And I do it anyways for my patients. But to be honest, it does kind of bring you up. And as you're saying, right, if you feel that someone's watching you, then you do it again and you do it more and you do it more. So I think it's great, right, to keep, we do see so many patients walking to so many rooms and so different things.
Mm-hmm.
What are your plans in terms of implementing this somewhere else, right? Because you want to, what are the goals? The goals, of course, is to improve hand hygiene. Is there any economical, try to make money out of this? How are you going to implement this somewhere else?
That's a great question. I think right now they're currently implemented. We have a variety of units throughout the AU Medical Center, the US University Medical Center.
Yep.
What we want to do first before expanding scale was see whether or not, by doing some chart review, see whether or not this is actually helping reduce the spread of infections. And that might take us a little bit of time. So before we expand, I think that's definitely in the plans though, to see if we can get these units to additional clinics, whether it's private practice clinics or other hospital units. But the immediate next step for us is trying to quantify the extent to which these units reduce infection rates, and maybe adjusting these units to see whether or not that might provide better infection control.
It may be difficult to get to those numbers. So, I think just hand hygiene is going to improve no matter what. Outpatient settings in the clinics, and if you put this inside the room and the patient is watching you, this is another thing that's going to improve the amount of people using the hand hygiene.
Wonderful. Thank you for your presentation.
Well, thank you for all your advice, and thank you for the opportunity to speak here.
Absolutely. Our next presentation is going to be with Ayush Sangari in a talk titled Evaluating the Extent to Which Posted Personally Identifying Information Jeopardizes the Privacy of Users of breastcancer.org.
Hi, everybody. My name is Ayush Sangari. I'm a medical student at the Renaissance School of Medicine at Stony Brook University, and I'm here to present our project, Evaluating the Extent to Which Posted Personally Identifying Information Jeopardizes the Privacy of Users of breastcancer.org. So essentially, breastcancer.org is a semi-anonymous forum where individuals can essentially share information about their diagnoses and treatments with one another to support each other. And it's purportedly anonymous, hidden behind a screen name. However, my co-authors and I were wondering how much personally revealing information is actually shared within those posts that might then make it possible to link an online identity with an actual personal identity. So the way we went about answering this question was starting by using Python to scrape all of the content in a thread called Chemo starting April 2018, which for over 2 years had 2,700 plus total posts from 64 different users. And what we did was we essentially looked at a post, which you can see up on the screen, and we sort of broke it down into its different components. So on the left, you can see a username, a location, and on the right side, you see the post content, as well as the signature beneath it. And what we did was we then took this parsed content and fed it into two pieces of software. The first was Filter, developed by UCSF for clinical de-identification. And they essentially look at protected health information, which is a HIPAA-defined category of 18 different topics, such as name, social security number, email, phone numbers, etc. And the second piece of software we used was Microsoft Presidio, which also does a sort of similar thing, but it's not HIPAA constrained or HIPAA defined. And that is primarily designed for business use. So after doing this, with Filter, we found that of the 70% of users that had signatures, there was an approximately 4.5 pieces of information, protected health information per each signature. And out of those 64 users, almost 50% of them actually had locations. According to Filter, in those locations, there was only about a third of protected health information per location, which when we went back and looked at it, was actually an underestimate. And as for the actual post content itself, Filter estimated that there was about 13.2 pieces of protected health information as defined by HIPAA per post. And again, we went back and sort of cross-checked it ourselves, and this was actually sort of an overestimate because Filter was essentially looking at people sort of like adding each other's usernames and being like, that's someone's name, when in reality it was someone's username. Next, switching over to Microsoft Presidio, when just looking at the post content itself, it found about 4 pieces of personally identifying information, and it actually has a breakdown of what it found. So by far, date and time was the most common piece of personally identifying information revealed, followed by person, which again, it suffered from the same problem Filter had, where it was catching people tagging other people's usernames and labeling that as people, and then followed by location. If we go back and then include the location and signature components of a post in addition to the actual post content, that figure jumps to about 9.5 pieces of personally identifying information, which is frankly a lot. So overall, we sort of realized that both of these pieces of software appeared to include many false positives. And to sort of address this in the future, we would like to do some more pre-processing ourselves to eliminate different screen names that people are adding. But also, we do know that, like, for example, Filter is a clinical de-identification text. So it might err on the side of over-scrubbing rather than under-scrubbing information. Next, we found that dates and locations appeared to be the biggest privacy threats, and out of those two, dates was by far the most common. One thing we didn't look at in this project, which we'd like to going forward, is usernames, as well as pictures that people shared. So in conclusion, we found that there is a significant amount of personally revealing information shared on breastcancer.org. We hope that breastcancer.org will sort of look at this and potentially proactively protect the privacy of its users going forward. Thank you.
Thank you, Ayush, for your great presentation.
Thank you so much for having me.
See if there are any questions.
One question that I have is is there any, I would say, benefit to, I know from like kind of a medical legal standpoint, we worry about patient privacy, but do you think that there's any, do you get feedback from patients that there's any that's helped them connect with other people in a different way than just kind of the general kind of, plus or minus anonymity of the chat rooms? Have you heard anything from, just to play devil's advocate, like is there a big problem that their privacy is compromised?
I think there could be, especially when considering that certain patients may have very rare genetic variants, so they might sort of reveal specific mutations that they may carry, and then that not only poses a threat to them, but potentially poses a threat to their relatives. So that's a problem we've seen play out, especially with the rapid increase in personal genetic testing posted. We hope that users are only sharing information that they're sort of comfortable with, people knowing, and wouldn't be hurt personally with this de-identification protocol potentially. But currently, I'm just not sure yet.
How did you get started or interested in this research?
So I have a background in computer science, so I was specifically interested in how privacy is maintained online. And I think, so this research looked at posts and post content. We did a follow-up study looking at username linkage, and we found that essentially about 2% of all users were reusing usernames from like Facebook or Twitter where their identities were actually revealed. So taken together, this study and the username study shows that there is a real threat out there from a privacy perspective. Not just sort of like a legal perspective, but more from a personal perspective. People online can know a lot about you personally that you may not have realized you even shared.
Sure. I think this is definitely a relevant topic in the modern era. We're learning that privacy and security is almost never guaranteed. So thank you so much for your presentation.
Thank you for having me.
Okay. Our next presenter is Aidan Sweeney, and he will be talking about establishing a framework for the introduction of genetic-based mosquito interventions against dengue in Thailand.
Good morning. My name is Aidan Sweeney. I'm a fourth year medical student at Emory University, and this morning I'm going to be talking to you all about establishing a framework for the introduction of genetic-based mosquito interventions against dengue in Thailand. A quick overview. First, I'm going to discuss some background on genetic-based interventions. Then I'm going to talk about my methods, offer my results, and finally conclude on how this study is relevant in global health and also in the realm of global surgery. So some background. There are two novel and more efficacious vector control interventions, one known as the release of insects with dominant lethality, or RIDDLE, and Wolbachia transformed mosquitoes. Collectively, these are sometimes referred to as genetic-based or GB vector control interventions. RIDDLE mosquitoes are transgenic mosquitoes with a dominant gene for lethality, and male transgenic RIDDLE mosquitoes are often released into the wild to mate with wild-type females, and in this scenario, the offspring of this mating all die in a late larval stage. So in this way, a RIDDLE mosquito release suppresses the wild-type mosquito population below the threshold required for dengue virus transmission. Similarly, Wolbachia is a symbiotic bacterium that is capable of blocking transmission and replication of the dengue virus in its host mosquito. Wolbachia transformed mosquitoes can only replicate with other Wolbachia transformed mosquitoes. So the release creates a selective pressure that results in the replacement of a wild-type mosquito population with a Wolbachia transformed mosquito population. And in that way, the mosquito population cannot transmit the dengue virus. Both techniques have demonstrated success in the literature, but there are some problems and obstacles in the way of their adoption. Perhaps the most common of these is the population's perception of the GB control interventions. In fact, we know that the public acceptance and engagement is necessary and essential for the implementation and success of GB control interventions. Therefore, the objectives of this study were, one, to investigate an association between mosquito distribution and Thai knowledge, attitudes, and perceptions on dengue and genetic-based interventions against dengue in Thailand, and two, to offer a framework for the introduction of genetic-based mosquito control interventions in Thailand. There were two study sites, one a rural district called Sayok in the province of Kanchanaburi, and two an urban district in Samphran in the province of Nakhon Pathom. At each house, a CAP questionnaire on dengue and GB techniques was administered, along with a 5-minute indoor mosquito collection using Procopac aspirators. There was two scores developed using the questionnaire. One was a dengue knowledge score, which had 3 classifications: excellent, satisfactory, and poor. And then one was a GB perception score of high concern, moderate concern, or low concern. These were developed based on the pilot study of the questionnaire. Our results: 1,200 mosquitoes were caught across 119 households. The QLS species were the most common in the rural district of Sayok, and the Aedes aegypti were the most common in the urban district of Samphran, which is consistent with what you'll find in the literature. Participants from both districts demonstrated a satisfactory level of dengue knowledge, and particularly both populations were highly aware of mosquitoes as the primary vector of dengue, the breeding location of dengue vectors, the importance of destroying water gathering containers and using insecticide for vector control, but they were less knowledgeable about other potential dengue vectors, the vector feeding times, as well as bed net efficacy. When it came to perceptions of the GB interventions, participants demonstrated a low to moderate concern on their release. And when we aggregated the average mosquito abundance per household and classified them by dengue knowledge and GB perception levels, and then ran a binomial regression, we determined that neither had a significant effect on indoor mosquito abundance, though we did note that households with a better understanding of dengue did have a lower mosquito abundance on average. The questionnaire included a series of statements regarding the hypothetical release of GB mosquitoes in the participants' community, and using the results from these statements, a framework for the implementation of GB techniques in Thailand was created. The first tenet in this framework is communication. Approximately 95% of study participants endorsed dialogue between community and members and scientists was important to them prior to a GB mosquito release. The second tenet is education. Approximately or nearly 100% of study participants endorsed that education was here on how modified mosquitoes reduce the burden of dengue was important to them prior to a GB mosquito release. The third tenet is that GB mosquito release needs to be comprehensive. In this study, approximately 80% of study participants endorsed that they buy mosquito protection products to protect themselves from mosquito bites and not necessarily from dengue itself. Therefore, a GB mosquito release that is more comprehensive and impacts more than just the dengue virus vector would be better received in this population. The last tenet of this framework is autonomy. The majority of study participants, particularly in SIOC, endorsed that the ability to end the project at any time was important to them in the hypothetical scenario of a GB mosquito release. So in conclusion, there are 4 tenets that should be addressed prior to the release of a genetic-based vector control intervention in Thailand, and those are communication, education, comprehension, and autonomy. Now, what does the study offer to the field of global health? Well, I think it underscores the necessity of community acceptance in creating sustainable global health initiatives, which I believe is a consideration at the forefront of many developers in the realm of global surgery and is vital for the continued growth of that field. So these are my acknowledgements back at Notre Dame, where I did graduate school and conducted this study, as well as my in-country partners at Cataract University in Thailand. Thank you.
Great presentation, Aiden. I don't see any questions right now in the chat, but I was personally wondering, what the latter part of your talk about autonomy and all of those different factors in the survey, what impact analyzing that will have on future projects that you pursue, just simply because I think that's a very important part in any global medicine project of, determining the participants' motivators.
Yeah, for sure. I think that doing this project, I learned that having understanding of what the participants and the community, understand about the project is really important, and is actually an important indicator on the prognosis and the success of the project. And that's something I really considered in some of the research projects I took on earlier in my research career. But as I've moved forward, they've become a lot more important when I'm setting up research design and methodology.
Great. We have a few questions in the chat. We'll probably only have time for one of them, but I'll save the other one for the networking session. But Dr. Sharma asks, do you have a sense from other communities outside Thailand what reaction and acceptance has been to genetically modified mosquitoes?
Yeah, that's a great question. So I can tell you that in Southeast Asia, there's a big hesitation to take on genetic-based mosquitoes because there's concern that there'll be horizontal transmission of the actual dominant lethality gene into other insect populations, and that's largely a misunderstanding of how the genetic-based mosquitoes are designed. Stateside, there's less a concern from the population from that standpoint, but over a decade they've been trying to get a mosquito release set up in the Florida Keys, about 750 million riddle mosquitoes, and they had to do 25 studies to demonstrate that there's no concern of horizontal transmission of this dominant gene. And just now, finally, after about a decade worth of research and work with the FDA and EPA, the Florida Keys is going to release 750 million riddle mosquitoes over 2021 and 2022 against the Aedes aegypti population, which is the #1 vector of dengue in the world. So we'll see how that goes.
Wow.
Just a quick question. Sorry.
No, continue, Dr. Serrat.
No, how long would it take for this to actually impact in places like Thailand the incidence of dengue?
Yeah, that's a great question. I'm not sure I'm the one to answer that, but with a multi-pronged approach, I think experts say it could you could see an impact on the dengue rates within a decade, because they'd employ the genetic-based interventions along with the traditional interventions of bed nets, etc. And within a decade, they would expect the dengue virus rates to drop. I'm not sure what it would look like on a larger scale, for the country of Thailand, but some of the county and provincial data suggests that it could have an impact within a decade.
Perfect. Thank you.
Wonderful. Well, our final presenter unfortunately was not able to join us, Saeed Tamid, but this is a good time for me to tell everyone that the abstracts of all presenters, including Saeed, are available on the Symposium's main website. If you scroll down and look at the schedule, you can see the poster presentation, and you can link to all of the abstracts as well as all of the presenters' contact information in case you want to reach out to them. So we're going to have concluding remarks from Dr. Serrat.
Well, I think this is it's been a great moment to see what all you guys are doing. This is all great research you guys are doing, learning from all the different ideas and all the different studies that are performed not only here at Emory but many other places. I really congratulate all of you guys for all the work you've done. I want to also, since we're here, let you guys know we're going to have 3 prizes for the first 3, the best 3 presenters for the posters. We're going to be releasing that at the end of the day today. And then also, I think we need to really thank all the people that is working behind scenes. Ian is one of them, but this is just great work. How things are working. This is a very difficult session to put together, to keep everybody in place, going live, going back and forth. Really appreciate all the work that all of you guys are doing. Abby and Erica, you guys have done a great job putting this together. So thank you all for being here today. I think we are done for today with the poster presentation.
Thanks so much.